My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to this public health conversation. These events are meant as spaces where we come together to discuss the issues that matter most to health. Through engagement with ideas, guided by expert speakers, we work to shape a vision of a healthier future. Thank you for joining us to today's event. In particular, thank you to the Dean's Office and the Marketing and Communications team, without whose efforts these conversations would not take place. We are at a particularly interesting and important time in thinking about health. As a country and as a world, the COVID-19 pandemic, with more than 7 million people worldwide dying from the pandemic, exposed their vulnerabilities more clearly than ever before. There has never, to my mind, been a more consequential time to ask how we are doing on health and what the future of population health is. This series of 3 conversations we are hosting starting today comes then at a very good time indeed. We are delighted to be hosting these events on the future of population health in partnership with the Milbank Quarterly. Throughout its history, the Milbank Quarterly has helped shape a conversation that supports a healthier world. It has been, and continues to be, a place where a range of voices can discuss the issues of consequences for health. Today, we are privileged to be joined by some of those voices, contributing authors from the Milbank Quarterly's 100th anniversary special issue, The Future of Population Health, Challenges and Opportunities. This is going to be one of 3 conversations, starting with today's topic, public health systems and structures. Before I turn it over to the moderator for today, I'm going to first ask Dr. Alan Cohen to make a few remarks. Alan is the editor of the Milbank Quarterly and was a co-editor of the special edition. He's also a professor in the Markets, Public Policy and Law Department of the Questrom School of Business and professor of Health Law Policy and Management, both at Boston University. Dr. Cohen.
Thank you for that kind introduction, Sandro. On behalf of the Milbank Quarterly, I am delighted to welcome you to the first session of a 3-day series of public health conversations related to the Quarterly's centennial anniversary issue. The overarching theme of the centennial issue is the future of population health over the next decade and the challenges and opportunities that we face as scholars, practitioners, and policymakers. The special issue was more than 2 years in the making. When we first began to think about how to celebrate 100 years of publishing the Quarterly, we considered a retrospective look at classic articles that we had published in the past. However, though we are rightfully proud of the many landmark articles that have appeared in the Quarterly, we felt that it would be far more intriguing to ask leading scholars to reflect on the challenges of the future and to offer policy prescriptions for addressing them. We settled on the central theme of population health not only because the Quarterly prides itself on being a multidisciplinary journal of population health and health policy with a strong interest in health equity, but also because population health is so vitally important to the future of the nation and the world. We were extremely pleased that Dean Galea and Paula Lance of the University of Michigan accepted our invitation to serve as co-editors of the volume. The special issue contains 36 articles comprising a wide array of topics in population health. This number of articles equals what we normally would publish in a single annual volume of the journal. Organized according to 6 broad thematic areas, the special issue examines macro and structural drivers of population health with examples including upstream policy changes to improve population health and health equity, the future of social determinants of health, human health and well-being in a warming world, immigration and immigrant policies, and the effects of urbanization on population health. A second area is state level and municipal level policies and strategies. Examples include state policy context in relation to population health, cities as platforms for population health, and the new era of restrictive abortion policy in the United States. The third area is key issues in population health equity, and examples include core principles of racism in health, equity-centered data to achieve health equity, child poverty and health, education in health, policing in health, and the need for affordable, accessible, and adequate housing. The fourth area is major population health challenges, and examples include obesity and chronic disease, the US overdose crisis, improving older adults' health, the future of public mental health, alcohol use in public health, and the future of firearm injury prevention. A fifth area deals with public health systems and structures, with examples including ensuring an adequate public health infrastructure, public health preparedness and lessons from the COVID pandemic, transforming public health data systems to advance population health, and the global health architecture needed to advance population health worldwide. And the sixth and final area is the US healthcare system, with examples including the role of primary care in improving population health, the workforce needed to address population health, and the next generation of payment reforms for population health. All articles in the special issue are downloadable and free for the next 3 months. I have no doubt that you will find many articles of interest in the issue. I would like to thank Meredith Brown and Erica Augustine for organizing the series of conversations on population health. They've done a masterful job of interweaving themes and speakers in instructive and synergistic ways. As Sandro mentioned, today's public health conversation focuses on the thematic area of public health systems and structures, and we are indebted to the 5 speakers for their participation in this session and for their outstanding contributions to the special issue. Over the next 2 days, the webinars will focus on major challenges in population health, followed by policy, governance, and social determinants of health. Please join us for both of those sessions. I hope you enjoyed today's webinar, and I invite you to dive into the special issue at your earliest opportunity. Sandro, I will turn it back to you, but before I do, I would like to thank you for your many contributions to the Quarterly. As a co-editor of the special issue, as an author, and as a longstanding contributing writer of thoughtful and provocative opinion pieces in population health and public health. Thank you.
Thank you, Alan. That's very kind. And thank you for what you've done. And thank you for putting together this 100th anniversary special issue. I'm now delighted to introduce today's moderator, Jamie Ducharme. Jamie is a correspondent at Time Magazine, where she covers health and science. Her work has won awards from the New York Press Club, Deadline Club, and the Newswomen's Club of New York, among many others. Previously, she was the health editor at Boston Magazine. Jamie's first book, Big Vape, The Incendiary Rise of Juul, was published in 2021. Jamie, thank you for joining us.
Thank you so much for that introduction, Dean Galea. I'm thrilled to be here today, and I know we have some wonderful conversations ahead. I would like to start by introducing our speakers for the program. First, we will hear from Tiffany N. Ford. Dr. Ford is a postdoctoral fellow with the Future of the Middle Class Initiative in the Center on Children and Families at the Brookings Institution, and is an incoming assistant professor of community health sciences at the University of Illinois Chicago School of Public Health. Dr. Ford conducts mixed methods well-being research that examines gendered racism in the health, economic, and social lives of Black people in the United States, and considers what it would take for Black people in the US to be well. Her policy writing is informed by her power building and sharing relationships with community-based organizations, community-led coalitions, and individuals most impacted by structural oppression. These ongoing connections inform her work, which traverses the social and structural determinants of health and well-being, and policy interventions to advance health equity at institutional, systems, local, and state levels. Next, we will turn to Kushal Kadakia. Mr. Kadakia is an MD candidate at Harvard Medical School. Prior to medical school, he worked on delivery system transformation across the public and private sectors. Kushal's research has been published in journals such as the New England Journal of Medicine and JAMA, and his writings on healthcare reform have been featured in outlets such as Harvard Business Review and Stat News. Originally from Houston, Texas, Kushal graduated summa cum laude from Duke University with degrees in biology and public policy as a Truman Scholar, and earned master's degrees in epidemiology and history from the University of Oxford as a Rhodes Scholar. Then we will hear from Beth McGinty. Dr. McGinty is Division Chief of Health Policy and Economics at Weill Cornell Medical College. She studies how health policies affect vulnerable populations with complex health and social needs, including people experiencing mental illness, substance use disorder, chronic pain, and others. Her work is characterized by integrating approaches from the fields of public policy, health economics, and implementation science to understand how policies affect population health. Dr. McGinty's research has been funded by NIH, CDC, and foundations including the Commonwealth Fund and Arnold Ventures. She has served on multiple prominent advisory groups, including a United Nations Technical Consultation Panel on Stigma Reduction and Drug Use, a White House Task Force on Suicide Prevention, and on the Joseph R. Biden Campaign Behavioral Health Committee. Then we will turn to Joshua Sharfstein. Dr. Sharfstein is Vice Dean for Public Health Practice and Community Engagement, Director of the Bloomberg American Health Initiative, and Professor of Practice and Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Previously, he served as the Secretary of the Maryland Department of Health and Mental Hygiene, the Principal Deputy Commissioner of the U.S. Food and Drug Administration, Commissioner of Health for Baltimore City, and as Health Policy Advisor to Congressman Henry A. Waxman. He is an elected member of the National Academy of Medicine and the National Academy of Public Administration. Finally, we will hear from Kurt Stange. Dr. Stange is a family and public health physician who serves as director of the Center for Community Health Integration at Case Western Reserve University School of Medicine. In that role, he is working to quietly nurture research and development for community health and for integrated personalized care, and to develop the capacity for shared learning for collective impact. At Case Western Reserve University, he is also a distinguished university professor and is the Dorothy Jones Weatherhead Professor of Medicine and Professor of Family Medicine and Community Health, Population and Quantitative Health Sciences, Oncology, Sociology, and General Medical Sciences. With that, Dr. Ford, I will turn it over to you.
Thank you, Jamie, for the introduction. I just want to start off first by saying hello. Thank you all in advance for listening. And I feel really excited to be here today. I do not take it lightly that I am the first person to speak on the first of these three discussions surrounding Milbank Quarterly's 100th anniversary special issue focused on the future of population health. And I think it's extra special, like my placement in this whole conversation, because the paper that Dr. Jamila Michener and I co-authored in the special issue is not only useful in opening our discussion today about public health systems and structures, but it also provides insight into where this discussion series ultimately will end up, which is with other co-authors from the special issue talking about policy, governance, and structural determinants of health. So, maybe it's a coincidence, or maybe that's why they put me here. I don't truly know. But I'm going to use my time with you all here today to share the key points of the co-author paper that we wrote entitled Racism in Health, 3 Core Principles. Now, I will not be using slides today, so y'all are just gonna have to lock into my voice, but jokes aside, as was said, if you all want to know more about what I'm about to share today, I hope that you will check out the full article, which is currently available online. So we begin our paper by acknowledging 2 hopefully obvious points. First, there are glaring racial inequities in all domains of human life in this nation, from housing to education to employment, wealth, and health, right? And they existed long before the COVID-19 pandemic. Second, we are not the first health researchers to say a thing about racism, right? And so instead of arguing that our paper offers an entirely novel idea about racism in health, we instead draw on a really wide and interdisciplinary body of literature, from public health to sociology to political science, to elaborate these 3 core principles at the intersection of racism and health-related work. And we detail their implications for research, practice, and policymaking for health equity. So what are those 3 core principles? First, racism operates in conjunction with interlocking forms of oppression. So when exploring and responding to racism in health, you have to interrogate racism and other forms of oppression, be it ableism or sizeism or sexism, right? You have to interrogate how racism and these other forms of oppression are working together to shape whatever particular reality you're focused on. And really doing so will offer a clearer view of how racism operates in the lives of racialized and gendered and classed people. Second, racial inequality accumulates because racism extends across multiple policy domains along the life course. Because of that, responding to racism in health requires multifaceted policy solutions that disrupt ongoing processes of cumulative racial disadvantage. Now, the 3rd core principle requires a bit of preamble. Race is not a biological fact that innately or inherently influences health outcomes. I just want to say that again. Race is not a biological fact that innately or inherently influences health outcomes. Race is a socially produced construct, and racism is a bundle of processes that operate through social, economic, and political systems to create, maintain, and exacerbate stratification according to race and according to socially constructed racial hierarchies. So the third core principle here is that racism is a function of power relations. So attending to racism in health and advancing health equity means examining the role of the state in shaping unequal outcomes, and ultimately, it means the redistribution of power. So those are the three core principles. Now, what do they mean for our work? We conclude the paper with thoughts on how researchers, advocates, organizers, government workers, funders, how they might advance health equity. And I really don't want to bury the lead here, right? So I'm just going to say the most important thing up front. The most important thing that we can all do to advance racial equity in health is to start where we are and consider where and how we can redistribute power resources to the people most negatively impacted by the inequality that we're focused on. So that means centering the voice or the ability to shape the policy environment of historically marginalized people. We also talk in the paper about the importance of health folks working collaboratively across disciplines and across sectors, and importantly, seeing themselves as in community with people-powered collaboratives and coalitions that are already working to exert control over the outcomes that shape their own lives. Finally, in the paper, we give a nod to some of our co-authors in the same special issue who argue that data equity is essential to health equity. So that's in the paper by Ponce and co-authors called Making Communities More Visible, Equity-Centered Data to Achieve Health Equity. And I hope you all will go check that one out as well. But in our paper, we also make the point that power redistribution and acknowledging heterogeneity within racial categories matters in all aspects of health and racism research, from deciding on research questions and constructs to making decisions about data collection, analysis, and sharing. So I will just end my time by saying that recognizing racism as systemic and a set of processes that manifest via overlapping systems of oppression, builds across policy domains along the life course, and operates as a function of power relations is an essential precursor to understanding the current state of public health systems and structures in the United States, and in crafting a reasonable response to support our population's health into the future. So thank you all so much for listening, and I really look forward to the discussion that's going to happen later on.
Thank you, Dr. Ford, for kicking us off with that wonderful presentation. Next, we will move to Mr. Kadakia.
Amazing. Thank you, Jamie, and thank you, Tiffany, for that incredible presentation. Today, I will be presenting on a paper jointly authored with Dr. Anesi Ofadil of MSK Cancer Center in New York City, and our paper focuses on the next generation of payment reforms for population health. Just to give a quick overview for today's talk, I wanted to start by first trying to give a common vocabulary about what we mean when we talk about payment reform. Oftentimes today in the literature or in the news about healthcare, you'll see words like value or payment thrown around very frequently as buzzwords, but I want to spend a few minutes really reinforcing why payment is important in the context of health. The second is I want to review some of the evidence we have from the last decade. And the third is really dive into the meat of our paper, which talks about an action agenda for 2035, which is a really critical moment because it'll mark the 70th year anniversary of many of the public payer programs in the United States, which of course are bedrocks of population health for millions of Americans. And so to start, I want to start actually with a slide that I remember seeing on the first day of my first public health class in college. And it's this fundamental inconvenient truth about America's healthcare paradox, that we spend far more, whether it's at the GDP level or per capita, on healthcare than any other country with our income level. And this money seems to be a pretty poor investment when we consider that the United States has significantly worse health outcomes, whether it's the prevalence of disease, the rates of mortality, or access to care. And more distressingly, in recent years, following the COVID pandemic, we've even seen a backsliding in life expectancy, really reinforcing that while there are a lot of resources in this country, the distribution of those resources is neither equitable nor efficient enough to get all Americans the health outcomes that they deserve. And of course, there are many reasons that contribute to high spending and poor outcomes, and payment is only one mechanism. But one of the reasons I think that financing is so important is actually a quote I heard from a government official named Rahul Rajkumar a long time ago, that how we pay for healthcare matters because payment signals what we value. I think this is incredibly important for centering any conversation around payment reform when we talk about what we're trying to achieve when we decide how financing systems operate and how we can better align those incentives for everyone across the public health system to better achieve population health. This is where it's useful to get a little bit of history, because historically, healthcare payments in the United States were conducted on something called a fee-for-service basis, meaning that payments were rendered based on the volume of services provided and the intensity of services provided. Of course, the issue with that is that if the incentive for a provider or for a health system is simply to provide more, it can create issues related to overuse, it can create issues related to waste, and it can create issues related to inefficiency, in particular because we might underinvest in the kinds of services that are better for health, but perhaps not best when it comes to a volume perspective. And so over the last few decades, there's been an effort among scholars and policymakers to try to shift this conversation away from volume and towards value. And a seminal paper by Michael Porter in the New England Journal is just one of many that helps to frame this conversation, where he talks about value as a very simple equation where the numerator is value to the patient, typically patient's health, and the denominator is the cost of the services required to deliver that value. And it's been a real focus of healthcare reforms over the past decade in the United States to try to move our system away from one that is defined by fee-for-service and instead towards one that is focused on delivering value to patients at the most efficient way possible. And over the past few years, there's been a guiding framework to try to chart out how these payment reforms happen. It's not possible for payments in the United States or healthcare financing to simply switch overnight. And so this phased framework has been developed by a coalition of stakeholders called the Healthcare Policy Learning and Action Network. And they talk about 4 different levels of payment reform, incrementally moving from fee-for-service, those volume-based payments, towards a true population-based model in which payments are set prospectively at the level of populations to better inform resource allocation, with a number of intermediate steps in between that include creating links to quality and creating accountability for outcomes. We've started to see some evidence for this because over the last decade with the Affordable Care Act, we had new opportunities to experiment with different kinds of payment reform. One of the many legacies of the ACA is the creation of a new government agency called the Centers for Medicare and Medicaid Innovation, or CMMI, which received funding and a mandate from Congress to run experiments with payment and delivery innovation. And a decade later, we've learned a lot from these experiments, mainly that it's really hard. Of the 54 different models that CMMI ran, only 4 actually met the criteria for certification, meaning that they sufficiently met those targets for savings and quality. The graph on the right side of the slide is from a CMMI evaluation. You can see that many of the payment reforms they tried didn't end up saving money, showing that removing waste from the system is complicated and requires a lot of alignment of incentives across stakeholders. At the same time, Medicare has been helpful by serving as a bellwether for payment reform across the healthcare system. While these reforms were focused on government payers, many commercial insurers also try to follow and emulate these policies. However, there's still a lot of work to be done, with the same learning action networks estimating that only 7% of healthcare dollars today are still in the ultimate goal of a population-based model, showing that while fee-for-service's transition away is far underway, there's still a lot of room to go before we can get to a more equitable and efficient financing system. And when we think about the lessons learned, there have been many retrospectives written, but our paper tries to really bucket these lessons learned into 2 groups. The first being that we've learned a lot of lessons about the process of changing healthcare financing. We've learned that if you want to shift things over, it's important for incentives to be mandatory rather than voluntary. That it's important for us to not just focus on one population or one payment group, but really think about coordinating with various kinds of payers and supporting different groups of providers based on the populations they've served. The second lesson, though, I think is perhaps more important, and that's that payment reform is about priorities. A very big focus of most demonstration models over the last decade has really been on savings, which of course is important given how much the US spends relative to other countries and the poor return on that investment. But less effort has been paid attention to how we can use payment to drive value, how we can use payment to incentivize and hold accountability for better outcomes and really demonstrate that progress. And in particular, how we can use payment to try to address these upstream drivers of health, which are often not covered within the healthcare system, and also close gaps in outcomes and access between different populations for whom outcomes have been so disparately different for so long in this country. Now, reassuringly, our paper comes out at the same time that these government agencies are engaged in a strategic refresh with 5 different priority areas, including accountable care, health equity, innovation, affordability, and partnerships. And so our paper is attempted to try and provide recommendations and analyses of these priorities for how we can help get there, but also look beyond them to think about what does it take to get the end state of healthcare financing, knowing that we are in the midst of this ongoing transformation and revolution in healthcare payment. And so for my last few minutes, I want to touch on these different issue areas very briefly to try to provide some context, which I hope we can discuss later on during the group discussion. The first is this concept of accountable care, which is the leading payment model that Medicare has invested in. The government has pledged to try to get every single Medicare beneficiary into an accountable care model by 2030. These are models in which providers take some level of financial risk for the patients that they are responsible for, with incentives for quality and outcomes. However, I think this story needs a little more context when we think about how we can approach payment reforms for these populations. And in particular, it's important to understand that the government payers we now have today are evolving rapidly. The majority of Medicare today is now contracted out to Medicare Advantage, which are commercial insurers that provide insurance for the elderly. And we're seeing actually a surprising growth in the Medicaid population, which is a federal-state partnership that provides health insurance for low-income Americans, and that now eclipses every other branch of insurance within the United States. And so as we try to achieve this goal of moving folks over towards these new contracts, we think it's important for payment reforms to take a broader lens of who are the populations being affected by payment reforms, and also explore how developing different payment reforms might lead to interactions between health systems, payers, and different stakeholders, and how we can try to reduce the friction in those interactions to make sure that we don't create more administrative barriers toward this goal of value. The second bucket is focused on health equity. And I want to point everyone's attention to the graph at the bottom left of the screen, which is from a paper in the New England Journal in 2018, where Karen Joint-Maddox at WashU basically plotted out the percentage of providers in each of these different value-based payment models and how many of them were being penalized if they were in a population that served a low-income or marginalized population. And those are in the blue blocks in the graph. And you can see very clearly that there is a disparate impact of some of these penalties on providers that are serving some of the populations that are most in need, showing that while payment reforms are often well-intentioned, there can still be bias built in these models, and that these so-called regressive payment reforms can actually have worse outcomes if they're not designed appropriately. The government, stakeholders, physicians are very well aware, as a decade of scholarship has done a really important job of illuminating some of these issues. And a goal moving forward is, as we design the next generation of payment reforms, attempting to embed health equity as an explicit objective of financing changes. And an ongoing model that was recently launched called the ACO REACH model is one example, because it includes things such as a health equity benchmark and requirements for providers and health systems to come up with health disparities assessments and plans of action to try to focus on payment reforms around actually achieving better population health. The third bucket is this idea of supporting care innovations. After all, payment reform shouldn't just be about contractual innovations. It should also be about changing the experience of what we're valuing and how patients receive care. And so in our paper, we argue that we can use the current set of payment reforms as we design them as a chassis to advance new delivery system reforms, such as the movement of healthcare from the hospital to the home. And we can also use it to rethink what we mean by care delivery, such as prioritizing new models of prevention rather than reaction. Much of our metrics today focus on things like hospital admissions, hospital length of stay, but by reorienting payment reforms and changing what we value, perhaps we could place just as much emphasis on preventing the incidence or progression of disease in the first place to keep people and their communities happier, healthier, and better. The next bucket is around accessibility and affordability, and this is an important new frontier because historically payment reforms have focused specifically on the health system, but not the medical products that health systems use. And in particular, CMS is really focused on designing payment reforms these days around high-cost new therapies and medical devices. We're seeing increasingly that a large percentage of Medicare and federal dollars goes to these therapies every single year. And there's been an emergence of new models to try to titrate payment for new therapies as we get new evidence. And so this is an example of how we can think with a broader scope and a broader valence of what payment reforms can do to try to address different levers of population health. And then the last bucket, and one that I think really nicely dovetails with many of the other themes of the papers in the Milbank special issue, is that system transformation shouldn't happen in a vacuum. It's something that requires partnerships. And there are early stage models that have been developed, like accountable health communities at the national level, or things like the healthy opportunity pilots in North Carolina at the state level, that show how payment reforms, when appropriately designed, can bring together groups such as public health, care delivery systems, social service organizations, patient advocacy groups, to try to work together to address some of these upstream drivers. And our hope is that by trying to identify these as priorities and importantly linking them to payment as part of this value equation, we can address what actually is causing health as opposed to just focusing on healthcare. So what I'll leave you with today is just a reminder, actually, from that original framework for that payment hierarchy written over a decade ago, that payment reform is not supposed to be a goal unto itself, but rather the vehicle for delivery system transformation. And what our paper challenges the community and policymakers to do is to make sure that this next decade takes heed from the lessons we've already learned and ensures that financing reforms are focused not just on the denominator value, which is cost, but also on the numerator, which is health for patients and populations. Thank you so much, and looking forward to the conversation.
Thank you for that fascinating presentation. Next, we will move on to Dr. McGinty. Over to you.
Thank you very much for the opportunity to share our paper on the future of public mental health and the challenges and opportunities involved in that future. The first premise of our paper is that the United States does not currently have a public mental health system, and it needs one. So what is a public mental health system? Following work by Jonathan Pirtle and colleagues, at a high level, a public mental health system involves three key spheres: social policy, which includes healthcare policies that could be directly relevant to mental health treatment, other public health policies that might be relevant to public mental health in a direct way, but also education, poverty, housing, other social policies that we know have a strong influence on population mental health. The second sphere is the healthcare system, which in a nutshell is responsible for screening and treating mental illness. And the third sphere is public health practice, which is a broad sphere encompassing a variety of population-based approaches to mental health, including prevention interventions, mental health promotion activities like campaigns, for example, and stigma reduction efforts. These spheres are overlapping. Social policy influences healthcare system and public health practice. Public health practice activities like prevention interventions are sometimes implemented within healthcare systems. So we need to think of these spheres as interacting rather than isolated. Currently, when we talk about the quote mental health system in the US, we are really talking about a set of healthcare services within the healthcare system sphere. And even there, where the majority of current resources and efforts are focused, we have a lot of gaps. 1 in 5 youth and adults ages 9 years or older, and 1 in 6 children ages 2 to 8 years old have mental illness in a given year. And 40 to 50% of them do not receive treatment. So even though currently our system is largely concentrated in one sphere rather than 3 spheres, even within that healthcare system sphere, we have a lot of ongoing challenges, which stem in part, although not solely, from the historic fragmentation of mental health services outside the general medical system, which is a long-standing remnant of stigma towards mental illness, and the inaccurate view that mental health is somehow fundamentally different and separate from physical health. In our paper, we go into some detail on partial progress, problems, and potential solutions moving forward in the public health practice and healthcare system spheres. We have seen over the past 75 to 100 years some meaningful but partial progress, including development of effective treatments and prevention interventions, the deinstitutionalization movement away from asylum-based care, which is very much in the category of partial progress in that the replacement of asylum-based care with a robust community mental health system has yet to be realized. And many of us in the field frame jails and prisons as our largest purveyor of mental health services in the United States as a result. We've seen progress in expanded insurance coverage of mental health treatment, although there is more work to be done. And we've seen increased, although still not nearly as wide uptake as we would like to see, of school-based prevention programs. Despite progress, we have major problems that overlay both healthcare systems and public health practice: provider shortages, system fragmentation, inadequate financing, stigma, and inequities where racialized populations, people who are experiencing socioeconomic distress, and others have disproportionately and structurally worse access to high quality care. Moving forward, there is quite a bit of potential to focus on. We highlight 5 particular areas, including the potential for digital health, things like digital therapeutics, app-based resources, the telehealth revolution to transform both treatment and prevention. There's very promising emerging evidence around the potential for brief, scalable interventions, single session, web-based interventions that have been shown, for example, to reduce depressive symptoms among adolescents, to really have potentially widespread impact on population mental health moving forward. There's excellent opportunity for embedding effective stigma reduction approaches within healthcare and other systems. There's some promising work starting to happen on use of community mental health worker models to help scale both treatment and prevention and promotion approaches in the United States. This is a model that has been used with great success in other countries, but uptake has been limited here. And global budgets and the payment reform movement presents opportunities to better align how we pay and organize healthcare with population mental health. The third core premise of our paper, and what I really want to highlight as the central thesis of my remarks today, are the role of social policy in population mental health. I've been thinking about this a lot recently in the context of Fleming and colleagues' public health paradox and the foundational causes approach. In their public health reports paper, Fleming and co-authors introduced this public health paradox, which is, in a nutshell, the idea that the federal government funds both causes and solutions to public health problems. The example they use to motivate this idea in their paper is the opioid crisis. On the one hand, we have government investing quite a lot of resources and making policy changes designed to stem the enormous loss of life coming from the drug overdose crisis. On the other hand, we have government upholding policies and devoting resources like drug control policy that are foundational causes of that crisis. This paradox also very much applies to the public mental health context. We have federal, state, local governments changing policies and devoting resources to efforts designed to expand access to effective mental health care and prevention interventions. At the same time, we have policy decisions that have led to major holes in the social safety net. And those social policies, we know, drive for population mental health outcomes. In a handful of timely examples, we have research showing that legislation banning gender-affirming care for transgender adolescents has adverse effects on mental health. Police killings have spillover effects on the mental health of Black Americans and other groups of Americans as well. And climate change is increasingly a driver of mental health concerns, particularly among young people. So in conclusion, this social policy area of the public mental health system really deserves a high degree of attention in the context of improving population mental health moving forward. Thank you.
Thank you, Dr. McGinty. That was fascinating. We will next move along to Dr. Sharfstein.
Thank you so much. And thanks to the Milbank Quarterly and to Boston University for having this really interesting session. This has been fantastic. I wrote with Dr. Nicole Lurie a piece in this journal called Public Health Emergency Preparedness After COVID-19. And it takes as its starting point a press conference that then President Donald Trump had on February 26, 2020. You will remember this press conference because he said, or I will certainly remember it, I'm speaking to you from Johns Hopkins, and he said, quote, Johns Hopkins, highly respected, they did a study, comprehensive, the country's best and worst prepared for the epidemic, and the United States were #1. And in this case, Donald Trump was correct. Johns Hopkins had led a study called the Global Health Security Index, saying which countries would be best prepared in a way, and the United States was in fact #1. It did not play out that way. As we all know, the pandemic has been devastating, and more than 1.1 million Americans have died, and that's just one way to measure the awful harm of the last few years. And so this paper asked the question, should this, on the one hand, by conventional measures of public health preparedness, the United States should have done great, but in fact we didn't. Should that cause a re-examination of the concept of public health emergency preparedness? And we think it should, and that's our starting point. What should we learn from this for the emergency preparedness work that happens in the future? And to answer that question, we look backward before looking forward. We start with 9/11, which is where we date kind of the birth of the modern public health emergency preparedness approach. And it's important to remember those days, if you can, when there was a lot of fear about terrorism, and particularly biologic terrorism. And the anthrax attacks that happened soon after 9/11 really framed the issue of public health preparedness as preparedness for terrorist attacks. And there was money made available, the first serious money made available across the country to respond. Some of that money went to technology, and I'll talk about that more, but a lot of money went to state and local health departments to buy things. And they were supposed to buy things that could help in a terrorist attack. And I remember at the time I was the health commissioner in Baltimore City, we had an entire hallway we had to close down because it was filled with stuff we bought from the grants. But the grants really couldn't help us with all the other things we had to do in the Baltimore City Health Department. And I remember meeting the Chicago Health Commissioner and complaining, like, I've got all this equipment we're never going to use, and it's in an entire hallway. And he said that he had an entire storage facility filled with stuff paid for by the preparedness grants. And interestingly, around that time, CDC was releasing guidance for how those grants could be spent. And there were all these specific scenarios we were supposed to respond to. And at the very end, in a section labeled Other Activities, there was one paragraph devoted to, quote, special populations. And it asked state and local health departments to, quote, describe activities that will be implemented to meet the specific needs of special populations that include, but are not limited to, people with disabilities, people with serious mental illness, minority groups, the non-English speaking, children, and the elderly. So the special population conception was well over half of the population. And it goes without saying that the concepts of equity were not really built into this field from the beginning. It was a lot about what you can do to respond to an event that may be caused by someone, rather than a more fundamental level of preparedness. And in the paper, we talk about that, and we say that that kind of cast a shadow on the development of this field over the next 20 years. And we walk through H1N1, SARS, Ebola, Katrina, and there's a pattern, which is money comes in and it is often used to buy countermeasures, buy technology, but it is rarely used to shore up core public health capacities. And it's interesting, we note this in the paper, that every time someone goes back and looks at how it went, like, how did it go with H1N1? There's people say, well, we were able to get the vaccine pretty quickly, which is true, but the public health capacity wasn't there. And we weren't able to reach populations that particularly needed to hear key messages or to get the vaccine. So it's sort of a theme bubbling below the surface. And ultimately, the approach that we take for emergency preparedness as a country leads to some pretty impressive investments in countermeasures. And that is testing platforms, vaccines, treatments, but it has other unfortunate gaps, including collaborating with other nations and seeing the connectedness of the world for some of these threats. There's a huge gap in the public health infrastructure. There's sort of an unstated assumption in these investments that there's an infrastructure to build on. But in fact, even as all this money was coming into state and local health departments, the health departments themselves were losing money and in many cases firing staff. So it was feast and famine at the same time in health departments. And that led to consequences for the degrading of laboratory capacity, the loss of many personnel, the inability to have a coherent data system, and a real starving of the ability of public health to connect with their communities and to think about equity considerations. And so we had a very weak public health system, even as billions of dollars were being spent for public health emergency preparedness. And this all came to a head during the COVID pandemic, where we saw the positive results of some of the investments, like the rapid development of safe and effective vaccines, alongside what I consider to be one of the major reasons why so many people died, which is such a ineffectual and gap-ridden public health system that couldn't do many things that needed to be done because of the underinvestment that we talked about before. And when we think about what public health should be doing, including to address some of the major equity gaps in society that contributed to very high rates of death in certain populations, public health had really been unable to do that by and large, for multiple reasons, but in part because of the underinvestment in public health as a field. So we conclude this paper saying that things need to be done differently. We cite the Commonwealth Fund Commission report on a national public health system, which talked about how important public health is to public health emergency preparedness, and talked about the need for consistent and stable investments in the public health system, the importance of strong connections with the healthcare system, the essential constellation of investments and approaches that are needed to build community trust and to support action against some of the fundamental causes of poor health. And our conclusion is that for the first 20 years, public health emergency preparedness had a lot of emphasis on emergency preparedness. But for the future, we have to really re-emphasize the public health part, put the public health back into public health emergency preparedness. And that is not to denigrate the investments that have been made and need to be made in countermeasure development and a lot of technology, but just to point out that that is just not enough. And we saw the consequences during COVID-19. Thank you very much.
Thank you, Dr. Sharfstein. That was so insightful. And last but not least, we will turn to Dr. Stanji.
So as a family and public health physician, I've been looking at the role of primary care in improving population health, both from the community perspective and on the ground and taking care of individuals. And like Kushal and Beth, I'd like to start with the paradox. So there's a paradox about primary care. If we look at the population level, based on ecological analyses, healthcare systems that are based on primary care have better population health, greater health equity, better healthcare quality at the system level, and lower healthcare expenditure. So better health, better equity, better quality at less cost. It's a pretty good definition of value. But the paradox is if we lower our gaze to the level of individual diseases, and that's how we really organize a lot of healthcare and public health, frankly, and incentivize it. Since primary care is associated with less evidence-based care of individual diseases. So it appears that there's some emergent property that happens between caring for individual diseases and then what happens at the level of the whole people and populations. Now, this paradox matters because we tend to focus on the parts. We tend to focus narrowly on narrowly focused programs, narrowly focused diseases. And focusing on the parts, we often do things that are actually at the detriment of the whole, of whole people and communities and populations. So how might we make sense of this paradox? And my colleague, Rebecca Etz, at the Larry Green Center, tried to make sense of this by asking hundreds of people, hundreds of healthcare providers, and about 90 people who pay for healthcare, what matters in healthcare? How do you know good care when you see it? And we did a lot of analyses of these data and came up with 11 different constructs that I'm going to list here that are worded in the words that people actually use to describe these. So people say it matters. My practice makes it easy for me to get healthcare, so being accessible. My practice is able to provide most of my care, so I don't have to decide if my chest pain means that it's my heart or my lungs or my esophagus or my stomach. I can just go and have a sense that most of my care will be provided. That when we go for care, that the people providing care will take into account all the factors that affect my health and not just their particular area of interest. That primary care actually coordinates care that people get from multiple places. And that people are known as a person, and that's an important context for care. That there's an advocacy aspect of this in a fragmented, often depersonalized system that someone will stand up for me when I need help. My care takes into account knowledge of my family and knowledge of my community. That over time, my care will actually help me meet my goals, focus on what's important to me. And over time, we'll do things to promote health, not just treat disease, but do things to help me stay healthy. So this came from analyzing these data, and we're vetted in an international conference called Starfield 3, at which we got 70 different experts from around the world to look at what matters in healthcare. And it's very interesting when people told stories about what matters, they got a good consensus, they got comfortable with what matters. And then when we tried to write individual measures, such as these 11 things, they started getting really anxious because they're saying, well, these things are trade-offs. It's not just focusing on one thing at a time. It's how this all works together. And this work did actually develop a measure. It's called the Person-Centered Primary Care Measure. And that's been endorsed by the National Quality Forum and the Center for Medicare and Medicaid Services in refocusing our attention in some of these alternate payment programs and ways of organizing care. I also asked my colleagues, Becca Etz and our colleague Will Miller, to get the data in a different way and saying, what if we look at this from the perspective of one idea about complexity science, that in complex systems, you can often describe very complex emergent properties with some simple rules. I said, there's simple rules that describe how birds flock together. And I asked them, let's think about how we look at these data, how we look at what matters from simple rules. And Will actually said, well, there's actually simple rules that describe how we look at things in a reductionist way when we're focusing on one particular program or disease. And these are very useful when we have a defined problem. And so these kind of specialist rules are we try to identify and classify disease for management. So when we're acting in a programmatic specialist way, we look at, does this person's problem, does this community's problem, does it fit with what we have to offer? And then we try to interpret that problem through our specialized knowledge in that problem. And then we develop and implement a management plan for that care. There's a complementary way of knowing and of providing things that improve health. And those are when we're acting like generalists. And this is tends to be what primary care does, although primary care and specialist care does both of these. So when we're acting as generalists, we have this broad scanning function. We try to look at the whole person in their community context, and we try to recognize and make sense of what the problems are that they bring us and what the opportunities are to promote health. And then based on this broad scanning function, we prioritize where we put our attention and action based on three things. Do we have something we can do to promote health? Do we have something we can do to foster healing? Or even if we can't do those things, can we do something to invest in the relationship that's like an interest-bearing account? If we invest in it, we can draw on that when the chips are down, when we really need to pull things together. And a high priority activity is something that both promotes health, advances healing, and fosters connection. And then we personalize care based on the particulars of the person. We take general evidence and say, what matters for this person in their family and community context? So what are some of the implications of these ways of understanding the role of primary care in advancing population health? Well, if we want these benefits that we see in these large system looks at the effect of primary care on population health, we need to take, I think, more of a bottom-up than a top-down approach that we need to do and try to support these integrating, personalizing, prioritizing functions that tend to be absent from a fragmented system that just focuses on one program or one disease at a time. So we need to support those on the front lines by trying to understanding that primary care actually has a complex function and a complex role, integrative role in a fragmented system. We need to support that with relevant information and time being money, time to invest in relationships and in an approach that goes back and forth between focusing on the parts and the whole, focusing on what's the most important thing we can focus our attention on in context. And I'll just leave you with these our final conclusions from our paper, the special issue with that.
Thank you, everyone, for those great presentations. At this point, we will move into the group discussion phase of the event. So I will ask all panelists to turn your videos on. We will be taking questions from the audience, so if you have one, please submit it via the Q&A system. But to start with, I do have a few questions of my own. I wanted to start with Dr. Ford, because after hearing so much about problems facing the public health system, I thought it'd be nice to talk about solutions. And you said something, Dr. Ford, that resonated, which was that you have to start where you are. You said it in context of redistributing power, but I think that applies really to every domain of public health that we heard about. So starting with Dr. Ford, and then others feel free to chime in, what does starting where you are look like? You know, what is the first step to improvement?
So, I mean, I think it really is exactly what I said in terms of voice, in terms of considering the power and the opportunity to shape the policy environment. So what that means for all of us individually, right? We're all showing up and operating in different spaces. Some of us are, you know, in the classroom as students. Some of us are in the classroom as professors. Some of us are, you know, delivering healthcare services. Some of us, right? Like we all show up in an assortment of ways in this work. And so what it means is to pay attention to how inequality is operating around you, just in general, and consider, just basically pay attention and consider what's going on. Consider who is not at the table for conversation. Consider whose voices or experiences are being systematically excluded, are being, you know, are placed in experiences where they are systematically experiencing a higher level of burden relative to other folks. And then if you feel that you have the power to speak on it, to just bring it up, you know what I mean? Do that. If you don't feel that you have the power to do that, build relationships, build power with other folks around you, have conversations about what is going on around you, and speak up about the inequality that you're experiencing really just in your day-to-day life, right? So that's the most simple and basic way that all of us, literally, no matter how we show up, can begin to address power imbalances, throughout our society. But I think that then, when it comes to like specifically researchers or specifically policymakers, there are even more things, like even more specific recommendations that can be made. But just in a general sense, it means pay attention, it means ask questions, it means build relationships, it means be in community with other folks.
If I could jump in just to completely agree and maybe extend that to the subject of our paper particularly, one of our strong recommendations is that the everyday work of public health be considered part of emergency preparedness, and the gaps that we saw in COVID should be made up, one problem at a time, one issue at a time, for all the issues that health departments are dealing with now. So just to the point that Dr. Ford made, that there are opportunities all around us, there are opportunities all around health departments to do a better job listening to their community, sharing power and resources with community. For example, Boston's new health commissioner came from a community coalition, having organized a community coalition around COVID, and now she is using the networks that she developed to begin to tackle other issues. She's using the current problems in front of them. And I think our policy should support that. Our policy should be investing in the ability of public health agencies to address the enormous challenges that are in front of them using the kinds of strategies that we know have been missing.
And I would add that those of us in healthcare and public health need to approach our people we serve, both communities and individuals, with humility and with listening. I think we have big data now. We have so much that we know that we can do proactively with prevention and with disease management, that we try to do things to people before listening to them. And I think we've actually lost the balance a little bit. I think people often, when they're working, they're trying to look for programs that will help them when they're trying to get help. And in healthcare, we're proactively doing so many things to them that we don't take the time to listen, to start where they are, and we lose our big opportunity to help that way.
Thank you for raising that. That's, I think, a theme that came up in a number of the articles that you've all written for the special issue, the idea that, you need to go to the source, you need to go to the community that is affected when you're doing research and hopefully making policy to address those problems. Excuse me, Dr. McGinty, I know this is something that you touched upon in the realm of public mental health. Could you talk a little bit about why it is so important to get affected communities involved as stakeholders?
Yeah, absolutely. Really, perhaps just echoing what you heard a few minutes ago from other panelists, that, this is the nothing about us without us idea, in that we should not be making policies or implementing programs that haven't been co-designed and co-planned and sort of involve the people who are ultimately the quote target, which makes it sound very unidirectional, which is what I'm arguing against, populations of these policies or interventions. And, in the public mental health context, we have a really terrible history in the United States of treating people against their will, and treating should be in quotation marks, and that often that treatment was sort of housing in very terrible conditions and not giving people the dignity or effective treatment that they deserve. And so in the mental health context, as in many other marginalized groups that have been marginalized for these very reasons, and there's a lot of distrust of well-intended, often policies and interventions. And so we have a lot of work to do to involve people sort of in the process from the get-go, and need to both not underestimate how hard that is and really commit to doing that hard work. I think the sort of co-production idea, which is this idea that policies and interventions should truly be co-produced by the people who will be affected by those policies and interventions, as well as producers of evidence and other relevant parties, as opposed to just like top-down approaches from researchers or policymakers or other experts, is really central here.
I just want to add on by saying exactly everything that Beth just said. That's what we mean when we say, power building, power sharing. Like, that's what that looks like in that particular research context.
Thank you for that. Continuing in a sort of solutions-focused vein, Mr. Kadakia, I wanted to go to you and just ask if you feel that there is a country that's getting this right, this balance of delivering high-value, accountable care, sort of a role model, if you will, that the U.S. could look to on this front.
It's a great question. And I think it's less about another country getting it right and more about what trade-offs other countries are making that we are making differently from them. So, for example, in the United Kingdom, which has a wonderful publicly funded system, the NHS, that has attempted to integrate health and social care, the issue is that funding is actually inadequate over time because it's declined over political cycles. And there's been challenges trying to identify the right organizational structure across the nation because things are allocated at the regional level. And so sometimes those resources haven't been directed upstream appropriately or have been aligned with workforce needs. In contrast, you might have really high functioning systems such as in Singapore, but scaling those from a single island country to an entire nation as big as the United States is much harder. That being said, I think that while we always reach for international comparisons in healthcare, in part because the US is such an outlier, it's helpful to remember that we have 50 states that are their own laboratories for healthcare reform, in large part because of the Medicaid program, which is administered on a state-by-state basis. And there's a joke among policymakers that if you know one Medicaid program, you only know one Medicaid program because they're all so different. I think North Carolina, where I spent several years, is a great example of this, where they worked over many years to now successfully expand Medicaid is a recent thing that's going on, but more importantly, not just increasing access to health insurance, but transforming payment for health insurance, creating actually a fee schedule for these so-called social determinants or upstream drivers of health. It's kind of like putting your money where your mouth is. If you want to talk about equity, if you want to talk about investing in things like housing and food, you can put dollar values in them and then try to allocate those resources to help people where they are. So hopefully those are some illustrative examples.
Yes, thank you so much. And I see that our audience question and answer box is starting to fill up, so I'm going to turn to that. The first one is also for Dr. Ford. Kayla Jones asks, what are some examples that have been done successfully to redistribute power by collaboratives and coalitions, or by government as well, if you have time?
Yeah, I mean, I want to start, first of all, thank you for this question. And it's a hard one to answer. I'll start with government because unfortunately there are fewer, at least like sort of documented, easy to find successful examples. But one example that we actually talk about in the paper is a Washington State example. So in 2022, they passed a bill aimed at increasing participation of folks with lived experience on boards, commissions, councils, committees, and other groups like that by allowing low-income folks in the state and other underrepresented community members to be compensated for their participation. So the bill included a stipend up to $200 a day to cover, as well, in addition to expenses to cover travel, lodging, child or elder care, right? Because ultimately, when it comes to advocacy for a particular issue area, you might be asking a low-income person to incur the cost of potentially time off work, might be uncompensated, right? Like travel to the location, whatever sort of care responsibilities that person might have had. Like there's so many costs involved in even participating in these participatory governance processes that this bill tries to help address. So that's a successful state level example. And then I think the initial part of the question was more so about like community-based examples, like in collaborative and coalition-based examples. And I think that's another one that is kind of hard because there's just so much happening like all over the nation, right? Like Kushal said, like we got these 50 states, and within all of these states, we've got all these different localities. We've got distinct issues, although a lot of issues tend to be interrelated. We've got distinct issues and distinct dynamics that are operating in all of these different places. And so we don't always see the like success stories like reported out in like the literature or things like that. But one example that I can share just from being here in Chicago and knowing some of the players here is, when COVID-19 was here, well, it's here, but for the initial response to COVID-19 in Chicago, we saw a partnership between local health departments, between local community engaged researchers who were connected to citizen scientists, and they were doing this work of sort of like disseminating hyper-local like health information and getting folks connected to the different resources. So to the point that some of the other panelists brought up about specifically Joshua brought up about just the lack of a public health preparedness system. Like they came together as a real-time intervention to help to build that public health capacity. So I would say that is a successful example, but the examples in that way, I would say that they probably abound, but it's harder to find sort of like an aggregated list of like all of the ways that coming together have worked. But thank you for that question.
Thank you for that response. That was great. Moving to another question, which I think Dr. Sharfstein or Dr. Stanji might be well positioned to answer. The question is, studies of the impact of medical care on population health in the US showed effects at most 10% of health outcomes. Do we want health or healthcare?
I want health. That's my answer. And I think, to the extent our paper talks about it, it's about health, not healthcare.
And we have disproportionate investment. I mean, the earlier question about countries that get it right. One thing I think we can take from other countries is that other countries that do invest in some of the kind of more of the social and environmental contributors to health than on healthcare that's so far downstream. So we really do have the balance wrong. And within healthcare, we need a greater investment in primary care, going from 6% to more like 12%. But then also we actually need to invest in the other things that are contributors to health beyond the downstream, the healthcare.
Sorry to ask a follow-up on that, but what are some of those other factors that we should be investing in before the downstream healthcare?
Well, we know that having equitable access to education is a huge contributor to health. That leads to a more equitable employment opportunities. It's not just the rich or the poor. I mean, the rich are clearly getting richer in our country, and that disadvantages everyone, including the rich. So education and what that has effect on equitable access to employment are important things. And then the environmental determinants of health, climate change, the things that we need to invest in that and make sure that when we're paying for things, we're really paying for the full cost, that it includes the environmental degradation.
Thank you. We have a question here for Dr. McGinty. Which government agencies do you believe should be financing and subsidizing the desperately needed group housing / supportive housing to meet the gap in the public health system?
Yeah, it's a great question and a timely one. I am by no means a housing expert, but I'll give you my 2 cents. I think in An ideal world, which is not the world we live in, so I'll give you the real world answer following my ideal world answer. But in an ideal world, we would have a strong authority through housing and urban development at the federal level that sort of flows down to state and local housing authorities, which is how, the system is designed. That system is broken. It is very under-resourced. And so, ability for people to actually access housing through that infrastructure via vouchers or public housing or sort of other efforts to support housing is, people face really long waiting lists. It's not viable in many places. So there are some really interesting experiments happening in the Medicaid space. By experiment, I mean natural experiments that Kushal talked about a few minutes ago. We have, several states. California is the most recent to be considering it. Arizona has done it, that are using Medicaid dollars to pay for housing. That is not, and will never be, in my view, sort of a comprehensive solution to our housing problem in the United States. It is one little corner of the problem, but a potentially important corner in that it's designed to provide housing for a discrete period of time, 6 months or so, to people who, in the absence of housing, are very likely to have dire health consequences, and potentially really high healthcare costs as a result of those consequences. So there's a cost case for states to consider this option. So, states are thinking about using Medicaid dollars, and in some cases trying out using Medicaid dollars for people who might be about to be discharged from the hospital and have nowhere to go. And of course, if they're discharged with nowhere to go, they're going to end up back in the hospital. Medicaid dollars to help people who are transitioning out of the carceral system and similarly have nowhere to go and have a lot of health needs that could be exacerbated very quickly. So keep an eye on what's happening in the Medicaid space. And, the reality is that we perhaps need things like these Medicaid experiences to plug holes, but in an ideal world, we need a robust system around housing and urban development that would fully fund efforts for the broader population as opposed to specific subsets.
Thank you so much. Moving to a question for Dr. Kadakia. This audience member asks about how various payment models might impact rural low-density populations. So much of modeling of financial models seems to have built into them a concept of market competition that simply doesn't apply in rural areas. Do we need different payment models for different populations?
This is an extremely important question, especially because we've really seen a hollowing out of the infrastructure for care delivery for rural populations with many, many hospital closures over the last 20 years. And managing both financial sustainability for those hospitals to be viable, but also sufficient resources for them to actually deliver the care that's needed for their populations outside the walls of the hospital is really challenging. I don't have a perfect solution here. I think this is a really open question for the field, but I think there are a couple experiments that can give us some insights. Number one experiment that happened in the last decade of payment reform was called the ACO investment model, or AIM, where as part of Medicare's larger efforts to create these value-based payment models, they developed a special one for providers in rural populations and serving other select populations, where they gave them some upfront capital to help them transition to these new payment models. Because part of moving towards a new version of reimbursement is also helping practices develop all the back-end capabilities to be able to do the data sharing, the care coordination. And that is actually one of the few models that ended up proving that it could save money, although it wasn't extended. I think is an example of how if we move towards these populations, there has to be resources and technical support to help them make the transition. Number two is an ongoing development in Pennsylvania, where Pennsylvania is adopting what's called a global budget model for rural hospitals. Global budgets are best known actually for their experience in Maryland, in which case there is a global cap that's set for hospital budgets across the state. And it's an attempt to kind of set payments, and Maryland has achieved nearly $1 billion of savings, in large part thanks to Dr. Sharfstein's leadership when he was the secretary there as well. And so while the results of the Pennsylvania model are ongoing, it's been complicated because of the COVID pandemic. I think that could be an example for rural populations. And the last thing I'd point out is that at the federal level, CMS is attempting to create new payment models for rural populations. They announced one called CHART, but actually this model, I believe, is ending prematurely because they've had some difficulties with stakeholders. So all of this to say is that there are many different options that are at the top of different folks' minds, but it shows there are challenges based on the type of provider, whether it's a community practice or hospital. It shows there are challenges based on the type of payer. It also shows there are challenges just aligning the incentives of stakeholders, because it's a really important resource for those communities, but getting it right is really, really challenging.
To piggyback on that, I'm reminded of what you said in your talk, Dr. Sharfstein, about how special populations actually was about half of the population in this report that you cited. How can we do a better job as a public health system of thinking about the wide swath of needs that we have in our population, rather than creating solutions that might serve one very specific group?
Well, I would say that rather than having equity be like this last detail in the application with, mentioning more than half the population, equity really has to be at the center of key issues for public health departments. And it's going to look different in different communities, what that means. In rural community, it's going to look different than perhaps an urban community. But the idea is that we have a core function of public health is to make sure that everyone benefits from access to health, and that there aren't unequal distribution of health harms, and that means really thinking about that pretty early on as an integral component of key initiatives. And that means having the systems and staff and connections with community organizations and nonprofit organizations and businesses to be able to accomplish that. And so in public health, we don't want to dial it back to 2019 and just keep going. Public health has to look different, feel different, be funded differently, accomplish things differently. That's really, I think, a common theme across all of our presentations, that, this is a moment, thanks to the Milbank Quarterly, to, envision a different way of doing things. And for public health, there's not a simple answer to your question, but I think it's that question has to be asked in the right way by the right people, in collaboration with their community, around all the issues that exist today that the nation's struggling with, as well as for emergency preparedness.
Thank you. We just got a question that I think all of you will probably want a chance to answer, so maybe we can do like a quick lightning round situation. The question is, addressing which single hurdle or issue would be most impactful for population health in the next 5 years? It's a big question. Let's see. I'll throw Dr. Stanji under the bus first. We can start with you.
I think anything we can do to foster recognition of our common humanity would be helpful. So, we just had a National Academy of Science, Education, and Medicine report on implementing high-quality primary care, and they call it a common good. And I think the reason is that it's a way of understanding people as individuals and not putting them just into groups. And I think that's how we need to approach things in public health and in healthcare. So how can we support people that are working at the scale of the personal, where people get to know each other, recognize each other as people, and then we can scale up to working on some of the larger problems. So supporting people on the front lines.
Thank you. Dr. Kadakia, would you like to go next?
I would say it's moving towards universal coverage for Americans. I mean, there are tens of millions of folks who still do not have access to health insurance. And so much of our paper that we wrote on payment reform is predicated on the idea that there's someone still paying the claim. Part of the reasons that costs are still a big problem is because no one else has them as an insurer to defray them. And, the ACA was a tremendous revolution in increasing access to care, but with tens of millions of Americans still lacking health insurance. And I think the current unwinding of Medicaid rolls after the public health emergency is just a timely reminder that this is still a gap that many, many people fall through. And it affects people at all stages of life, from childbirth all the way until old age.
Thank you. Dr. Ford, anything you'd like to add?
First of all, I love these answers. I would like to say history, education. I think it feels critical to come to as much of a shared understanding of the systems and structures and policies that led us to our current place as possible, so that we can begin to move forward together, or as much of together as possible.
Thank you. I think we just have a couple minutes left, but I do want to get to Dr. McGinty and Dr. Sharfstein. So if you have any lightning fast thoughts to add, please do so.
I think we should prioritize continuing some of the social safety net expansions that happened under the COVID-19 pandemic, particularly child tax credit expansions and unemployment insurance expansions, which are key contributors to reducing poverty that underlies so many of our health problems in the US.
Yeah. I just say I'd like to see health moved out of the political fray a little bit. I think when we're in such a politicized world, it is very, very hard to make progress in the United States. And it's just very unfortunate that some really core issues for health have become so politicized. And if we could somehow unwind that, or, stop the forces that are winding it up tighter, like misinformation, then I think all of the efforts that we're talking about would be easier.
Thank you all. This has been such a wonderful discussion. I've really enjoyed moderating it and hearing all of your ideas. And with that, I will turn it back to Dean Galea for some closing remarks.
Well, thank you, Jamie, and really thank you to all our panelists. As Dr. Cohen mentioned at the beginning, I've had the privilege of working with a special issue and reading all these papers, but I learned very new things in listening to you all, both in your presentations and in the conversation. So thank you for being a part of this. Thank you for everything that you do. I want to thank the audience, a really engaged audience, excellent questions and excellent comments. And for everybody who's interested, we have a panel 2 tomorrow and then panel 3 the day after. Everybody, thank you for being a part of these conversations. Have a good afternoon and evening. Take good care.